I'm Tom Chiller. I'm the chief of the Mycotic Diseases branch at the CDC in Atlanta, Georgia, and I'm thrilled to be here at IDWeek talking about Candida auris. I know that many of you have heard quite a bit about Candida auris, and we were here today and yesterday at the conference presenting some updates and some of the newer epidemiology that we know about this organism. Let me start by saying Candida auris has been a particular challenge for us in trying to get laboratories to identify it. We know that around 25% or so of the labs in the US can identify it using a MALDI-TOF or a DNA sequencing instrument. So we're still working hard to make it better for labs to identify this organism. And I want to say that if you see a Candida species that you don't know the name of, that's a rare species, check with your microbiology lab. It could be that you need to forward that to CDC or to the state lab and let us help you identify it. We want to help identify these Candida species and especially obviously Candida auris as it is occurring. Second thing that we've been talking about here at the conference is resistance. This is really the first Candida species that we have seen that can develop resistance to all three antifungal classes. That is obviously in the category of superbug, and we don't want a fungal superbug, but we may have one on our hands. Thankfully, we haven't had any cases of triple resistance in the United States yet, but we have seen it in other parts of the world. And so it's going to be really important to think about appropriate treatment when you're treating Candida auris. We still recommend echinocandins. However, unfortunately, we have now seen a couple patients develop echinocandin resistance in their Candida auris while on echinocandin therapy. So we need to be thinking about the resistance in this organism, getting people on appropriate treatment, and getting the isolates tested for their minimum inhibitory concentrations to these drugs so that we understand what the resistance patterns might be. The other thing we've been talking about a lot is colonization. This Candida acts like a bacteria. It colonizes the skin, and it can stay on skin. We've documented up to 9 months of its ability to stay on skin. That's different. We don't think of that with Candida. We think of that with MRSA. We think of that with other bacteria that are transmitted in hospital settings, but we don't generally think of that with Candida. So this colonization issue is a problem, and if you identify a patient that is colonized with Candida auris on their skin, they need to be put in contact precautions, and they need to be treated as though they're always going to be colonized with Candida auris. We're still working on decolonization strategies and source control. We need more information about that, and we're looking to the clinical community to work with us on trying to figure out how is it that we manage these colonized patients. And then finally, we worry about its transmission in healthcare settings. Remember, this is a paradigm shift for what we're used to with Candida. This is a Candida, a yeast acting like a bacteria. So it's transmitted readily and easily in hospital settings. You can find it on surfaces. And in fact, it's very happy to remain on surfaces for weeks, probably months. We also know that quaternary ammonium disinfectants do not kill this organism. So we are recommending a higher level of disinfectant, a C. diff, sort of sporicidal disinfectant, until we learn more about disinfectant strategies. So, in summary, paradigm shift for this organism. Likes to colonize skin, likes to develop resistance and stay resistant. Hard to identify using the typical things in microbiology labs, so we need to be thinking about MALDI-TOF DNA sequencing and sending isolates out. And then finally, it's easily transmitted in hospital settings. The one other thing that we're going to talk about, that we've talked about this week while we've been here at IDWeek, that has been a bit concerning, is that some of our cases we have seen that, that have Candida auris in, let's say, the non-sterile sites. So not in blood, but instead in urine and in wounds. The challenge there is that we don't tend to speciate our urine isolates. And so we're recommending in our newest clinical update, which you can look on our website to find out more information, that you consider speciating Candida in urine in patients that have come from an area or a healthcare system where Candida auris is present. And you can look again on our website to find that information out. So thanks for letting me share a little bit more about Candida auris with you today. Have a great conference.